So it's now my privilege to introduce our second speaker for our session today. Our second speaker, his name is Terry Gold. Terry is going to talk about on the topic of healthcare evolution, challenges and roadmap for identity in healthcare. That's his topic for the next hour. And Terry is his bio is as follows. He's the founder of iDanalyst, which is a vendor-neutral research and advisory firm specializing in identity management, security, and privacy across both physical and information-based environments. For the past 10 years, Terry has been dedicated to developing strategies for some of the largest companies in the world concerning their planning and execution of their approach toward identity management, credentialing, and vulnerability assessments. Terry also presents at various conferences, including B-Sides, DerbyCon, ISE West, and is a co-organizer for Security B-Sides-LA. Terry holds a bachelor's degree from Jacksonville University and resides in Southern California. So it's a privilege once again, to introduce our second speaker for our symposium this morning, Terry Gold.
Yep, that's right.
Thank you, Terry, for coming this morning.
The mic's not flying. So, there we go. All right. Well, thank you. What a great conference. So this is awesome being here. As I begin here, how many people are on the information security side? How many people are technical? How many people are more on the business side of healthcare? Not very technical. Okay. And then, are there any other type of people here that are neither? Okay. So, it's a little too loud here. I'm just going to adjust this. A little too loud. I don't want to kill you guys. Okay. Is that better? Yeah. All right. So my background is in digital identity and trust frameworks. And so that can mean different things to different people, right? So we talk about identity, we think identification, we think licenses, we think any type of credential, tokens. But my history in identity begins about 15 years ago. And we're talking about how the identity itself is made, what it's made up of, how it's bound to the person, how you know who that person really is, and then across different environments, contextual use. So when you look at a given person in a digital environment, what makes them them, right? You have attributes about you that get stored in different places in different systems, right? And different systems handle that identity in different ways in interpreting it, okay? And we've always been in the world of identity. If you look at identity, we've always been in the world of identity going back, centuries to know who people are, okay? It's really becoming critical in healthcare. And we're at a crossroads right now because healthcare is a very complex vertical. I've worked in information security for 15 years, and not to dismiss any other industry out there, but when you look at the unique dynamics of healthcare, it makes it really unique and very difficult to solve. Okay, there's so many things about it that are different than any other industry, like, who really is a consumer. If you go buy a car, it's a person buying the car. In healthcare, well, some people think it's a patient, but most of the time they're not really paying the bills. And there's a lot of unique dynamics, right? So it's very hard to solve, okay? And it's a necessity. So this presentation is going to be about identity in healthcare, what it means to the business process in healthcare, the big problems in healthcare that we have with continuity of care, improving outcomes, fraud. A lot of these things we debate, and they're not technical challenges, but technology is part of the solution. And identity is a big piece of that. And there's a lot of initiatives right now that are happening that are pushing healthcare in the direction that is changing and going to change the whole provider landscape. And I find that most organizations right now are so focused on HIPAA and a lot of other things, and they should be, because it's a very, very critical environment. But a lot of these things are off their radar, and they're happening. Okay? And the biggest thing that you can take away from this is that if you're not looking at them, you're probably going to be making decisions that are counter to them. And it's just going to make the problem worse later on. Okay? So we're going to talk a little bit about, in this presentation, the big picture challenges in healthcare. Maybe most people in the room know that. We won't spend too much time on it. What's really driving the industry for change around identity? And we're going to spend some time around identity. Like, what's the status quo? What's going on in a typical payer-provider environment? Why? Does it really meet the current requirements? What does that look like against the future and evolving requirements that are coming? It's kind of a big question. I find that a lot of providers are pretty insulated within themselves, making decisions within their own environment. But the biggest change that's happening is that they're going to have to look outside their own environment for the requirements. It's a little bizarre. I'll explain it. And we're going to talk about some of the standards against the healthcare initiatives that have really very little to do with the demand of security when we think about it, like meaningful use. It's really all about outcomes and the usage of electronic records in technology and putting them to use. So we typically don't think about, what do you mean? What does identity have to do with that? It has a lot to do with it, okay? And I'm going to break that down for you. And there's other initiatives too. And then the last thing I'll do is I'll probably draw a couple of examples of what's going on out there around the world, around the country, what kind of a technology implementation decision might look like. And I'm not really promoting any one solution. I'm a vendor-neutral analyst. If anything, I probably upset vendors most of the time. But that's okay, right? I think the most important thing is to know where things are going. Don't worry about coming out of this presentation and saying, okay, how do I get it right? Because there's a lot of things in motion, you're probably not going to get it right. You just really need to be aware, right? So if we look at identity throughout the years, it started out pretty basic, right? So you paper documents, but the technology probably wasn't around in the 1920s to go ahead and forge a paper document. You get into, the 1970s, they start putting photos on it, and you start getting up to the 80s and 90s, and, I'll admit, when I was 16, I was able to dupe one even way back then, in my early, pre-hacker days, and go get a beer, right? So not very secure. If a 16-year-old can do it, you probably don't want to go ahead and rely on something mission critical that is really protecting something. But there's been an evolution. So if you look all the way to the right, there's a lot of chip-based cryptographic technology embedded in a lot of these devices. So that could be in cards. It could be every passport since 2007 in the United States gets issued with a cryptographic chip. And there's encryption, and there's PKI certificates in it. And if you go get a new passport right now, they won't issue one without one, right? So the whole world is evolving to stronger proof of identity, okay? So what does that mean in the real world in terms of security? And then we'll hop back to healthcare. So for the non-technical people in the room, when you look at kind of the economics of the threat ecosystem, you just pretty much look at what the target is, right? So you have a lot of things that hackers could go after. Intellectual property, research formulas, designs, whatever it is that's worthwhile to them. Now, you got to ask, who are they, right? There could be individuals, or it could be groups of people, like state-sponsored, organized crime. It's typically not just the lone kid drinking Coke, in the basement anymore, right? This stuff's a lot more orchestrated, especially depending on what they're going after. So that's the basic stuff, right? What are they going after? Who's doing it? It's the stuff in the middle that when you really look at it, I walked in at the end of the last presentation talking about target. What I'm amazed is the stuff in the middle, right? So when you look at the attack surface and the environment that the attackers try to look at to see, how am I going to go ahead and get in? I'm going to do some recon, okay? I can do that over the network. I can do that, attack the applications. But once they do, the interesting thing is they get in somewhere. It doesn't really matter. And they start to execute multiple attacks. It's not just one thing. Okay, there's probably 100 different things that hackers will try to go ahead and do once they get in. Okay, and the fact is they're going to get in. Okay, I mean, if you live in an environment where you think your security is based on keeping everybody out, I think you're probably going to be disappointed later on. Okay, it's a matter of, can you go ahead and execute a kill chain before they go ahead and get to something important? Okay, what they do when they get in, at the end of the day, they're trying to go ahead and get elevated privileges. They're trying to impersonate authorized users, and if they can impersonate authorized users that have administrative control over the systems, they have greater level of access. They can erase their tracks. They can make new policies. They can control the server. They basically put themselves in a position of command and control. Very dangerous. And that's pretty much what most attackers, that's like the golden prize for them. And that's what they're always trying to do. And, that's pretty much what happens in a lot of attacks, okay? Now, when you look at administrative controls, I bring that up because that's identity. Okay, I mean, the username and password of the administrator account is assuming that you are the administrator. You have those credentials. You enter the credentials and you prove that you are the administrator to a system. Fine, great, you now have administrative control, okay? And we know passwords are weak, right? So there's been an effort to go ahead and improve things to get beyond that. Now, let's get back to healthcare. Before I go into this, what I see in a lot of provider markets is how many people here have heard talk within their organization to go to just leveraging the building access proximity cards that they have, because they have them, and they're convenient, just touch it, tap, get in. I mean, come on, I don't see any hands, but seriously, I mean, it comes up all the time. Don't do it. It's a step backward. And if anybody in the room knows me and they caught me in my presentations in Vegas or DerbyCon, I can actually show you how easy this is to exploit within about 5 seconds. Okay? So here's a little chart, and you can get this. I wrote a white paper on this. It's downloadable on my website. It's not promotional. It just breaks it down from a healthcare perspective of when organizations are trying to go ahead and improve the convenience and the security at the kiosk level, and they wish to go ahead and leverage an investment they already have that seems to fit that bill, I find most of the time they don't really look at the technology because they're not familiar with it. It's not an IT technology. But if you look at it just in the way that you normally vet your current vendors and technology, right? So somebody says, oh, well, it's encrypted. What type of encryption, right? Well, if you did this with proximity, you'd realize there is no encryption. There's no security design built in it at all. At least for the proximity, it's in 90% of the provider markets in North America, okay? So the problem is that it's an encoded password on it. There's no username. It's just a number, that's it. It's not alphanumeric. It's clear text. It can be written over, it can be snooped, it can be everything. And it's vendor assigned. So it breaks one of your other rules, right? We typically don't want vendor assigned passwords. You can't change them on scale. And you get them through the channel. So whoever sold them to you knows what your passwords were. The vendor knows. You can't really audit where they store all that information. And it's just out there, all right? But the problem is that it's worse than your current password management policy, because at least your password management policy says, a character alphanumeric every 30 days, every 90 days. Only we know what it is. We can change it. You can't even do that with this. And then when you go ahead and implement this very insecure building access technology into an IT environment, all bets are off, because when I can go into an environment that has proximity, it's not just the snooping and cloning that people talk about with these things. That would just be one area right here, like right here. Let's just go ahead and snoop the number. I can attack all these different things to get the number. Once I have that number and I get on your network, I am that person. It's very dangerous, and you wouldn't know. It's undetectable. And I don't have to just get that one number. I can figure out all the rest of the numbers. And if anybody has any doubts, if anybody looks at any of their building access cards they have on them, I won't make an example out of you, but if you pull out of your pocket, you'll see on the back of your card that it's highly likely that the password is actually engraved on the card. I'm not kidding you. because that's standard practice in the physical access world. So for me, I wouldn't actually engrave a password on a laptop and order from Dell and tell them to send me the laptop with a password engraved on it. That's just not the way to go. So this isn't the type of stuff that we're talking about. All right, so if you look at the rest of the landscape and you see that proximity is really down here somewhere, so the higher up you go, the more secure it would be. The further to the right, the more standards-based it would be. And if you look at all the different credentials that prove who you are in the marketplace, from tokens and proximity and magstripe to all new stuff that's coming out like near-field communications and wearable tech and ultra-low powered Bluetooth, like all these cool, crazy things that are going on out there, here's the matrix, okay, that I put together. And from that perspective, you look at it in two different ways. How secure is it? And then how open and standards-based is it? The reason why I ask how open and standards-based it is because without any transparency on how that technology is built, what the algorithm is, then I have no validation. There's no public testing against that technology to really validate it. If I'm a proprietary vendor, give you an example, there's a physical access vendor technology, it was this one right here, right over here, that said they were the most secure for 10 years, and they wouldn't hand it out to anybody to test. A researcher finally tested it and broke it in about an hour. Compromised probably 100 million users that are out there, and you can't fix it. So open standards gets you transparency on what's going on underneath, but there's a difference. It doesn't mean you're giving up the secrets of the technology to protect the actual security within that element. So if you notice, the lowest security stuff is really the stuff that's not standards-based, because it just doesn't get beat up enough around a community that doesn't have a vested interest in calling things out and improving it. And if you look at the stuff that is really secure, the most secure, typically it's standards-based, because community's involved in the specification and they're involved in the testing. And when there's a problem, like if you look at the US government and their personal identity verification where they've issued smart cards with certificates to over 10 million people, if there's a problem, it gets solved because you have 10 million people across over 200 federal agencies saying, we got a problem, it needs to get solved. You don't have one person begging a vendor to say, we really wish you would update this, right? So it's really important, especially with technology that's critical. In the middle here is what I call kind of the area of obscurity, where it could be more secure, but again, it's proprietary. Depending on how they do it, you really can't validate it, so it's still a question mark, right? Really quick, just on payments. When you look at the evolution of identity in healthcare, the payment market's already going there, right? So it didn't happen overnight. Like right now, how many people have heard of EMV, chip and PIN? Right, so credit cards over in Europe and overseas, they have a smart card chip in them, right? So they have a chip in them. You go over to Europe right now as an American and hard pressed to make a transaction. In October 2015, that's all going to change over here. You're going to get cryptographic certificates inside of this credit card. That's been a long time in the making because of fraud, right? But there's been many advancements over the years. Healthcare is now starting to go through that transition, saying just using proximity cards or passwords or tokens really isn't going to cut it anymore. There's different drivers and there's a different direction, and we'll talk about that. So what's causing that different direction, right? You have stakeholder challenges that really have nothing to do with technology. You have what I would call three different stakeholders. You have the beneficiaries, obviously, like the patients. You have the providers that actually deliver the care, and you have the payers that pay the providers. And they all have similar buckets of challenges. So you have, but I think they experience the challenges in different ways. For instance, the provider cares about how they can deliver the quality of care, right? In what environment can they deliver the care without as much restriction? Can they get enough access to information to improve care? Like, this person walked into the ER, what are they really allergic to? I have no idea. Who's their doctor? They're unconscious. I don't know. I wish I had that information. Or I wish I could go ahead and onboard them much quicker than it can today. It might take me 20 minutes to go ahead and get somebody through the paperwork, but wouldn't it be great to have technology when they walk right into the building, it automatically pulls their record up even before they go ahead and get to the registration desk? Like efficiency, right? On the other side, the payers are really concerned about, is this really the legitimate person that's getting care, right? Or is this fraudulent? Is the doctor really providing that service, or are they overbilling? Is there phantom billing going on? Is this beneficiary eligible? Maybe they're the right one, but maybe I terminated their benefits last month. How do I know that in real time? And then obviously the patients, they want quality care. They want access to their information, right? So I mean, for me, I can't even get access to all my healthcare data right now across all my different doctors, my different locations. I get bills from all over the place. It's kind of a mess. And then even when you look at Google's healthcare application, the challenge with that was they couldn't solve it because they couldn't get, they offered a service for individuals to aggregate their healthcare data, but they couldn't get it from the different providers and EHRs and everything out there. So the whole infrastructure is kind of very messy, right? And so when we look at that, we've all been focused on HIPAA. But HIPAA's going to stay here. It's not going anywhere. But what happens after HIPAA, right? So if you look at HIPAA was all about getting records from paper to electronic form to enable portability. Okay, it wasn't about security. Security was kind of in effect that we had to deal with. But I think some people lose sight of that. And HIPAA's been kind of so focused on security within information security and healthcare, we've taken our eye off the ball in a lot of ways. But what's after healthcare is now, okay, we got stuff in electronic form in a lot of places, right? What do we do? Well, there are some drivers out there to say, here's what to do with that electronic data now. You have to interact with it. You have to let patients access it. You need to let them be in charge of the records. You need to be able to go ahead and have quicker access to care. You need to be able to send reports and diagnostics to other doctors electronically. And the payers want increased visibility into all the things like metrics and fraud, and if they go ahead and pay another $1 for a procedure, what would the outcome be? And so there are initiatives really forcing this now, and meaningful use is really it's not a mandate, but it's incenting organizations by way of dollars and money, because you get money for doing it, to head in this direction and use that electronic data that we've all gotten into electronic form and tried to secure and have policies around, to have meaningful interaction. And really where that's going is through healthcare information exchanges, right? So how many people have heard of information exchanges? HIEs, right? Okay, good. The challenge with that has been that it's been very fragmented, right? So to get hooked up to a health information exchange has been very difficult, right? So you have to have these basically legal agreements with the other organization that you want to go ahead and have a meaningful exchange with, and that gets into policy, it gets into all this stuff, and it doesn't scale well. So HIEs really haven't taken off as much as everybody thought they would, even with some mandates in some areas. And then now you have other mandates like electronic prescribing. It's not a mandate, but while that's taking off and you want to go ahead and prescribe controlled substances, then you're forced to go ahead and have stronger identity that meets federal standards. Okay, you can't just go do your own thing with proximity cards or tokens anymore. Okay, so there's a lot of things going on. Now, if you want to go out to a healthcare information exchange, that is saying that you are being required of somebody else that they need to trust you. Okay, they're probably not going to accept your proximity card. They're probably not going to accept, well, you just sent them an email and kind of wrapped it up in some object. We have to have a way that we agree that we know we trust each other and how we handle the data in transit and at rest, okay? Or otherwise, how do we really do that, okay? And that's wrapping it up in policies, process, and certainty of identity is central to that, okay? Not just that you have a strong credential, but when you first told me that we're going to have meaningful exchange, how did I go ahead and vet that that's really you, right? So it goes all the way back to the beginning, okay? So what are some drivers out there, right? You know, I mentioned a couple of them, and there's some silos, right? So if you look at the silo method, that's been the traditional method in the provider market. It's, hey, I want to protect the kiosks. I want to go ahead and make easy access for the doctors, because most of them don't even want to use passwords anyway, you know? Just make it simple. You know, they just want to improve kind of convenience and ease of use and say they check the box for security. But that doesn't really require anybody else telling you that they don't accept that method. Okay, so you can do what you want. But with all these incentives coming down, and there's several of them, there's electronic prescribing controlled substances, there's meaningful use stage 2, there's stage 3 that's going to come, there's addressing fraud, there's some incentives there. There's virtual care, community outreach. I'm working with one of the states back east on how they actually scale to reach mental health patients in communities to avoid situations that we've seen lately, because people don't come in for care, you got to get to them. But you can't do that on a send the doctors out to every house in the neighborhood. So a lot of virtualization is taking place, again, over the electronic environment, the virtual environment. So it's very important that people that are sharing the records in that virtual team environment, you know, they have strong trust and agreements between them and can execute that. And on the other side, there are mandates, things they have to do. But this incentive bucket really is driving a lot of this stuff, right? And the siloed approach of, here's what I think I want to do to please the doctors and have more convenience and just have this kiosk and single sign-on stuff, that's not driving it anymore. And if you let that drive you, it's going to be one big dead end. I'm not saying you can't address all this stuff while addressing the others, but you got to have your eye on the right prize in order to do it, or you're going to be left out in the cold. So how do you do that, right? There's something in the government that NIST put out, right? So NIST is like the agency within the federal government that makes standards, National Institute of Standards and Technology for federal government, right? And the federal government has really done a lot around identity and security. And they've broken it down to 4 areas. Whether I agree or not, doesn't matter. But LOA stands for level of assurance, okay? And they go 1 through 4. So LOA 1 is very low level. There's really not much going on. 2 is basically adding that aside from a username and password, we actually proved who you are. We probably went out to like an Experian and checked your information and what you're telling us and made sure to a reasonable degree that you are who you say you are before you get your credentials working. And then level 3 gets into like multi-factor. And level 4 is like cryptographic devices and keys, really secure like the government does. And when you break it down that way, and I start to exchange policy on who I am with different relying parties, if we agree that, hey, level 4 is agreed for this transaction, okay, then I need a level 4 credential for this transaction. For a different transaction on the same person, you might only require a level 2. So it's very interchangeable around what the risk is. And when you look at your risk, it breaks down to a similar process. You take your risk, you take your person, and you proof their identity, and then you need to go ahead and have a challenge and a response. And depending on how strong you want to put that challenge out there, in how meaningful the response will be. So that would be like you're requesting a password. Okay, that's not very strong. Or it could be you're requesting a PKI certificate with a private key. Right? That's pretty hard to spoof versus, and so it depends on what you're trying to enforce. And then of course the validation. The validation happens in multiple ways, right? So what I'm saying is you really have to go ahead and look at this from a best practice standards level. How interoperable can this be with other organizations, because they know that you're both talking about level of assurance 3 versus level 2. It's not just some custom bespoke proximity card or some other thing that you use that you want somebody else to accept, because they won't, okay? Now, what needs to happen, right? So things need to get stronger. You need to have policy frameworks for the credentialing to define what these levels of assurance are within healthcare. They need to be useful and meaningful, but you need to have a framework in which you can go ahead and communicate with other exchanges without having direct agreements. Because having a direct one-to-one agreement every time you want to go ahead and exchange with another organization is costly and doesn't scale. Okay, so that's what's kind of being solved right now. And if you look at meaningful use, it demands sharing structured information around from providers to patients amongst different EHRs, different vendors in different environments. Okay, so right now EHRs typically they don't know how to talk to each other, right? From one doctor to another. So the requirements for meaningful use stage 2 are laid out here. When you look at the HIE requirements within meaningful use stage 2, it starts to break down. This is the HIE stuff. This is saying, here's what you need to do around interaction. Then there's this other stuff called the direct HIE. And this is all about securing the transaction in between around identity. Okay, and if you don't believe me, it's in there. Okay, it's right there in the standards and the ruling. Okay, it's right there. So you have to do it. Okay. So let's talk about direct. Direct is basically securing that structured data in an email transaction. So when a doctor emails another doctor or messages another doctor, or patient messages a doctor, and in including laboratory results and all this stuff, you're basically wrapping it up in a PKI certificate transaction. And it goes through your EHR, and then it goes to a provider that knows how to handle that security, and then it goes to the other side. I'll skip around a little bit. It kind of looks like this, and it's a little messy, but the sender's right here. It goes through EHR. It goes through their provider, SMTP, basic technology that we know if it applies the certificate, and then goes to the other side to the other sender in the same process. But there are standards around that. But if you look at it, different EHRs. And now they're communicating through each other. And it's a secure transaction. And the direct actually came out of ONC. It's a defined messaging. And what happened was the group that was working on it said, that's great that we defined it, but at the end of the day, if nobody knows how to do it, and if you have multiple organizations implementing this, but they still can't trust each other because they don't really know exactly how they implemented it, like, what exactly are their policies behind implementing it? If I don't know the other relying party's policy, how can I trust them? I don't know, right? I don't know how they proof the identity. I don't know exactly what type of encryption they used. So, we can communicate, but we're not going to trust each other. So what they did was they broke off and they founded a nonprofit called directtrust.org. What they do is they provide a specification and a roadmap where everybody can build to the same specification and then get assessed and credited through ENAC. Everybody knows who ENAC is, right? So they do a lot of the electronic assessments for accreditation in healthcare. And so they do a lot of stuff around HIPAA. And so what that does is if we all go ahead and build to the same specification, it gets validated that we did, and we're doing it the same way, when I go out to an exchange, I don't need to ask you for what your policies are. I don't need to go ahead and have a special agreement with you at all. All I need to know that how you're doing it is accredited and it was audited. It's transparent. And now when I go ahead and build this once, I can use it many times from many exchanges. And it's really taken off. There's about 30 states in the US right now using this in their exchanges successfully. There are others implementing it, and this thing's just like doubling every quarter. In healthcare, that's pretty impressive because it's been a long slog around this stuff. So it's been really good. Now, and the other thing that it does is it increases the communication, right? So it increases the communication between state agencies, private care, different types of private care, whether it's hospitals, provider offices. So you're able to go ahead and link up all these meaningful messages instead of faxing and calling and doing all these things where everybody trusts each other. It's pretty cool, and building it just once. Now, there are some limitations. Direct only addresses messaging and identity, but it doesn't address authentication, okay? So it doesn't authenticate the individual like when you authenticate to a website. That's not what it's focused on. It's focused on, I know who you are, and I know how to secure your message. And at the individual level, we'll leave it to you on how they authenticate to that infrastructure and that message. So there are some gaps there, but you can still apply what you want and still have the trust. I'm not going to go through all these, but these are other initiatives going on to address varying levels of assurance, whether it's user authentication, whether it's messaging authentication, and it's pretty confusing. There's something called Cantera, which is an identity framework, and that is to go ahead and link up different organizations just in terms of how they communicate with one another. Before you even send the transaction, how they link up and how they can do that. And there's debate on, there's some overlap with how they deal with proofing versus how Direct does. So ENAC and Direct and Cantera have all gotten together and said, hey, let's try to figure this out because we got states out there looking to do this stuff and they don't know which one to do. So they're just telling us to do all of them and it's pretty expensive, right? And we have to audit probably 90% of the same stuff because we're all doing similar stuff. So they agreed to do a feasibility study inside of Cantera in a health identity assurance work group. Unfortunately, I'm leading the charge there. I say unfortunately because it's a lot of work, but they're cross-mapping and comparing all of them to then give guidance, but also maybe get 3 of those organizations to say you don't have to get assessed and audited 3 separate times. Maybe there's some reciprocation around you did 90% of this here. That's good for us. Work on the other 10% and decrease the cost and the timelines. So we're working on what might come out of that. But here's the takeaway. A takeaway is that HIMSS has recently just formed an identity management task force, and their whole goal, because all this stuff is so confusing, I've been doing this for years and it's confusing to me, but their whole goal is to break down what's going on and what you should do as a provider. That hasn't happened before, so that really excites me. So if anybody wants information on that, I can give you some contact info, but they have scheduled delivers in 2014 to be able to help give you guidance on this. So it's really good stuff. So getting back to the business solutions, you want to address phantom billing and environment cost reductions through inefficiencies, improve the claim cycle process, card swapping for the wrong people aren't getting care, and have a common framework. Now, don't get into the technical solution too much, but what a lot of providers are looking to do is say, if I could have continuity of care information inside the card instead of just having a dumb paper card that shows up. So they show up and I know what their last procedure was. I know who their primary care doctor is. I know what they're allergic to, even if they're unresponsive. Their card is intelligent. It's locked down. It's not this radio frequency free read. It's cryptographically locked down. It can only be locked down, opened up in a certain environment, then it's locked down again. You can use that to recall records as soon as somebody walks in. There's a vendor out there that they put kiosks in hospitals, and the patients swipe the card that got issued. They swipe it, and it checks them in, enrolls them automatically, walks them through this, and then when they get done, it does the same thing on checkout, saying, this is your next visit, the whole thing, and it automates all the follow-ups. It's like really cool. It cuts down all the enrollment. And then there's other cases where, I have a client that was down when Katrina happened, and they were flooded. All their paper records were gone. Their computer systems were down. They had to provide care, and they couldn't really figure out what anybody's records were. It was really hard to provide care to people. Forget the liability. They were just in dire mode. So they're for about 1.5 million people, including all the beneficiaries and providers in the state, are going and getting rid of their paper card and going to a smart card that can hold all this information, and it acts as a backup whenever they need it inside of a situation like that. And we're actually doing the strategy on that because it involves a lot of stuff that hasn't been done before. It's been done over in Germany actually, but we're not the same as Germany. Germany is a single payer system, so when you have different systems and different EHRs, it's a little bit more complex. You can't just do what Germany did. But there are countries that have gone out there and done that, where it has a lot of the continuity care on the card, and it's meaningful, right? So, aside from getting into the technology that can do many things, there's this huge fraud problem that we have, right? So I was actually surprised to learn that, out of I think it's like nearly $400 billion in payments that Medicaid and all these payments that go out from CMS, about 98 billion of it's fraud. It's kind of crazy how much fraud is going on out there. And, some of it's phantom billing. A lot of it's just we don't know who the doctors are that just set up a location and they're organized crime, and we didn't really prove their identity right, and they just sit there and bill for a month. They bill everything from pacemakers to everything, and then it's a pay and chase models. A lot of states, they just have we pay within 15 to 30 days, and then we investigate if we see something wrong. The detection systems are so horrible, they never really catch it, and if they ever do, they show up, they just show up and they see an empty shell. Nobody's there. Nobody was ever really there. They made $2 million, moved on, they're down the road somewhere doing it all over again, right? So it's a big problem. So identity applies to this whole fraud problem. You know, when doctors gets licensed and you proof them, you know who they are, add a strong credential, they can reuse that to prescribe controlled substances, interact meaningfully in other ways. What Germany does is kind of cool. They actually have mutual authentication. So when a doctor and a patient are, they're engaging in providing and receiving care, they both insert their card into the same reader, and it gets stamped on the transaction. And what that tells the payer, it tells the payer that the patient was there at the time of the transaction, the procedure, so this is not a phantom billing. And of course, there's like a pop-up saying this is what you're going to be billed for, do you accept? And so that's how they're addressing phantom billing. And it goes back to the very strong identity of it, because it's not just a credential that I can spoof. It's cryptographically signed. And it goes back to when you first even questioned who I was before I got issued. So there's some examples in here you'll be able to find, but there are some studies that have been done by AMA that had just emulated the pandemic situation. I think it was at the Superdome, and they had two groups, ones that had these smart cards with all this continuity of care data in there, and the other ones that didn't. And the results were like really shocking. How much it actually automated, how much it actually changed the procedure and the care method that they employed, how many people actually needed this type of care versus that type of care. So they took a shot at it. It was pretty good. And so state of Texas out of that has begun that whole initiative. So now doing this stuff's very complex. So just to give you an idea, if you want to tackle it, it involves all this stuff. It's a lot of stuff that you have to go do. Okay, so I'm not saying to go do that. Don't go rush into it. And you can make it easier now that there are service models behind it. There weren't before. So the service models can eliminate a lot of this stuff that you wouldn't have to do, and be less costly. But at the end of the day, there's something called IDP, and all these. And this is the last thing I'll finish with. Organizations have been really struggling with identity and credentialing, because if you want to do it better and stronger, what you typically had to do is you had to go ahead and take the project on, implement it yourself, resource it, spend the money, issue it to everybody internally and make it work, right? That's a big cost. I mean, we're in the healthcare business. We're not in the security business. I don't want to spend $3 million doing all this technology with all my resources. I got other things to do, okay? Now, what's going on to change that to really look at? Remember we talked about the exchange of meaningful information through health information exchanges? While that's going on, something else is going on in the identity market, where it's called IDP, or identity provider markets, right? Where the basic concept is this: if we agree on definitions of what level of assurance 1, 2, 3, and 4 is, we talked about that, right? We all agree there's definition of what that is. We can validate it, it's audited, you're certified, all this stuff, right? Okay, so we can trust that. Now, if you have infrastructures in the middle somewhere that say, I know how that when you go ahead and request checking whether this identity credential is belonging to this person and it's valid, I can go check with somebody that issued it and tell you, then it means you don't have to issue it. So that means if another provider or another agency issued an identity credential and you have confidence by the level of assurance that it is designated, why would you issue it if you can go back to that provider and validate it? So instead of going into your own infrastructure and looking for an authentication, you basically say, yeah, I'm requesting a level 3 credential for this transaction. If you don't have to give me the one that we issued, we might not have issued one. go back to the relying party that issued it. We're going to go back, and you'll be able to, in the transaction, you'll know who issued it, and you can go back, your infrastructure can go back and check with them and let them do the authentication, come back to you and say, yeah, it's good. Now what this means you don't have to be in the business of issuing all these high credentials anymore. And you can not only accept and exchange information, you can accept the assertion of the identity that are out there in the wild. Right? So you don't have to be in the business of tokens anymore. You don't have to be in the business of smart cards and passwords and proximity cards. You could actually just say, you know what, oh great, that doctor, you also are a doctor in the military. I know they issued this smart card that's a PIV card with cryptographic certificates. Great, you know what? Why don't you just go ahead and show us that when we ask for a proof of identity? And you can automate that, it's like a snap into your system. And then when they bring it up, it goes out to the Fed, to the OCSP, and says, yep, valid. Great, you didn't have to issue that card for $250 a year per person, right? So there's a really big gain there. So you can address not having to build all these things and rebuild all the connections to the exchanges as well. It's pretty cool. The last thing I'll finish with, because we're not going to, and this will take a minute and then I'll take questions, because we're not going to get to everything, is something called UMA, User Managed Access, right? And when all those other things break down, that in healthcare is a little bit odd, because you know, if you're looking at the giving doctors identity credentials, they come to the office, you can issue them. If you're looking at large populations of beneficiaries and patients across rural areas, how are you going to distribute this stuff? How do you proof them? How do you validate them? You know, a lot of people, they don't have cars, they don't have phones. I mean, you'd be surprised, right? So how do you issue 1.5 million people like the project I'm working in, right? So there's a lot more technology going on that's virtual, but there's something that's critical that's coming up right now, and it's very recent. So Cantera Initiative had been working on a specification for user-managed access, and it gives the average end user control of their identity credentials. Just think about what this would mean like in the side of like Target, where they had that whole fallout, where I could go ahead and control all my identity attributes, and somebody like Target has to come back to me to ask me how they use it and how they store it. And if I don't want to allow them, they can't do it. I'm in complete control of my different electronic attributes, okay? And so the user-managed access lets me dictate how I interact with the digital world rather than services telling me what they need and just doing what they will with it. What that means is that not only can you use credentials, but you can enable the patients out there to centrally manage and reuse credentials from other places. And you just tap into that UMA registry, right? Does that make sense to everybody? It becomes a lot more dynamic. So you can not only accept things from other organizations, but you can also put these beneficiaries in control to go ahead and centralize what their identity is and how they interact with your services. And when you demand a level 2 or a level 3, they can just pull it out or say, no, I decline it. It's pretty cool stuff, and that can all be done digitally. So with that, I'll just say, before jumping on any of this stuff, the last thing you really always want to do is measure the outcome, but do a risk-based approach, because there are so many different models out there. There's still proprietary models. There are standards-based ones that are early, they're evolving. And what I do with my clients is say, okay, look, let's go through all the different types of points that if I were a business executive or I was the chief medical officer or the CIO, I would want to go ahead and say, here are all the elements that may or may not be important to me. And I put a scale together and I help them weigh out what their perspective of that risk is, because I'm not making the decision for them. And you lay those options over one another and you find out really quickly what you can and can't live with, so that way you don't waste a lot of time investigating different models. If one's just not going to work for you from a principles perspective, you'll find out right away. And that's, I think you cut out a lot of time going that route. And then the one that you arrive that has the right attributes that you think you would want to go with, then you really focus on vetting that one. And my concluding statement will be, with the HIE stuff with direct trust, that's there today. This other stuff around identity, it's still, there's a lot of like beta going on, right? But it within the next year or two, I'd be looking at it to be planning on how do I embrace that in the next year or two. So if you have identity credential or identity and authentication initiatives going on internally, I'd kind of put a little bit of a chill on that while I look at what's coming down the road. How do I join up with that? So from that perspective, that's pretty much what the presentation was trying to get to. So thanks very much. I'll take some questions if anybody has any. Yeah, sure. Sure. Yeah, that's a really good question. So the simple answer to that is whoever issued the credential that you have, and it could be multiple credentials, like you mentioned your bank. There's a program in Canada where the banks issued you your credit card. So there's the assumption that they went ahead and proved your identity, they got your passport, all that stuff. So the whole healthcare system in Canada is looking to go ahead and use that card for authentication for health services, right? So what happens is when they go ahead and it's an EMV chip card, when you use that financial card for a healthcare transaction, all that healthcare transaction says is, I want to see something that's level 3, something with a chip and something with a cert on it, okay? Okay, so you present it. When they see you present it, they say, this is a level 3 bank card. It's intelligent enough to do that. And then it goes back out to the bank and says, hey, is this really the bank card you issued? Can you check? Can you go ahead and do some random key generation in the chip and send it back to me? I mean, you're not involved, you don't see that happening, but that's what happens. And then it comes back and tells the healthcare environment, yeah, it's valid. Oh, okay, authorization. There you go. Right? So it's leveraging something that somebody already issued to you, and it just depends on whether that person wants to accept it or not. But since now I'm pushing the authentication back to the issuer, I don't have to issue it. So I could have things that are issued to me all over the place that I could use, like a wallet. And it doesn't have to, the traditional model has always been that the issuer has to be the one that authorizes it, which is still the case, but you can be a beneficiary of that now. And there are federal models in that, by the way, in the federal government. You can get certified, and they do that between agencies, so it's very secure. And then there are private models. Actually, SecureAuth, right outside, I just saw them walking in, they're a commercial IDP. So they go in and within like a week, they implement an IDP where you can do all this, right? You won't be federally certified, but you can still go ahead and authenticate a federal credential. Just depends on what your environment is. So, is there any other questions? All right, thank you so much. I appreciate it.
Thank you, Terry, for your time and attention to this more afternoon now to this important topic. And once again, on behalf of the LA ISSA and the HIMSS chapter, Southern California chapter of HIMSS, we want to present you with a little certificate as a token of our appreciation.
Wow.
So thank you so much
for
your time today.
Thank you.